Welcome to Open Range, and today I am filling in for Gary Emeneth, and we will be discussing a very in-the-weeds issue. And for those who don't know me, I am the Managing Director of the North Dakota Watchdog Network, and you can find my material at watchingnd.com. Today we're going to be discussing a healthcare issue that has popped up in the legislature this session, which is being visible in House Bill 1473, which is tackling one of those federal programs that has letters and numbers in it. We talk a lot on this show about 45Q, but today we'll be talking about the 340B program related to healthcare and pharmaceutical rebates and reimbursements and that sort of thing. And with me today is a gentleman named Kent Kaiser of the Domestic Policy Caucus. Kent, how are you doing today?
Good. Thanks for having me on.
Yeah. So, to our viewers and listeners, give us an idea of what the Domestic Policy Caucus is first.
Right. Well, we're a nonprofit organization where we deal with public policies all across the country, state by state. And so we do operate in any state where there are issues that are of interest to us. And we work with state legislators and we work with the public, try and educate on a variety of different issues. And 340B, this healthcare issue, is one of them. We have many other issues, and people can check out the website, domesticpolicycaucus.com, to learn more about all of the different issues that we work on. But again, we work on the state level with state legislators and state level policymakers, governors, and others, in order to make changes to, or sometimes to stop public policy from taking place. So we're active right now in probably about 15 different states with different policies. And the one that we're talking about today is an issue that we're working on in several states where legislators are discussing 340B.
Yeah, and this is a fairly new issue to me. Even just in the last 2 weeks, I've been exposed to this. Some background back in the original fight over Obamacare, as in my role as executive director of the North Dakota Taxpayers Association, I was the point person in North Dakota for the U.S. Chamber of Commerce against Obamacare. North Dakota was one of the few states where the state chamber didn't really want to take on that role, so I ended up doing a lot of that. But this particular issue, from what I've read, Obamacare probably made it a little bit more problematic. It's been around, this 340B program, since the early 90s. And it sounds like it's one of those programs that started out with very good intentions and just kind of metastasized and has gotten out of control. And the regulators and regulations related to it have been taken advantage of by some of the players. So if you could give us kind of your version of the background of this issue, I think our viewers would appreciate it.
Yeah, you're right. This law was passed in 1992, and it's just a section of the law. And unfortunately, there isn't a glamorous name for it. It's just referred to as 340B, which is the section of the law that it was in. And that was the Public Health Services Act of 1992. And so yes, you're right that it was well-intentioned, and a lot of people were on board with it. It's a very popular program when it first started. With the pharmaceutical companies liked it, and the patients liked it, and policymakers liked it. But there isn't much oversight or transparency, and not too many guardrails, if you will, on the law. And so at this point, it's really kind of out of control. Now, it's really, again, well-intentioned, because the idea was to mandate that the pharmaceutical companies would provide discounted drugs to the hospitals and safety net hospitals, that is, and to other covered entities, as they're called in the law, which are all really for people who are really in need and the most vulnerable patients, to give them so that those discounts would be passed on, those pharmaceutical drug discounts would be passed along to the patients. Well, unfortunately, that's not the way that it's worked out, because again, without the guardrails there, without any, not even a definition of what constitutes a 340B patient, the pharmaceutical companies were providing these discounts, but those weren't making their way to, those aren't making their way to the patients. And so you have to look at who's in the middle. Well, what's in the middle, of course, is the hospital systems and the big box pharmacies that they contract with, and those that contract with the federal government for the Medicare and Medicare and Medicaid programs. And so at this point, what we really have is a situation where it's kind of out of control, where there's huge money going to these hospital systems and to physicians, and really not making their way to the patients. And so what we're advocating for are some reforms so that we can get that money, or those discounts, I should say, to the patients where they belong. But right now, it's been for quite some time, actually. I think it was a 2013 report or an article in the Journal of the American Medical Association, which pointed out that most of the benefit of the 340B program is actually going to the hospitals and the pharmacy chains and to the doctors, and really not making it to the patients. And as we all know, of course, you hear about it all the time, how drug prices are going up and up and up. And so unfortunately, the discounts really aren't making it to the patients at all.
Yeah, and as we see with anything to do with government, when there's a tax or fee, every nickel of that gets passed on to the patients. But when there's a program designed to pass along savings, unless the law specifically dictates it and somebody's there to enforce it, the hospitals, the pharmaceutical companies, anybody involved is going to do what they can to capture whatever margin they can, because they're in business to do, and that's how they have to stay in business. And it's my understanding that some of the savings that are intended with this program end up being held over in a way that causes the hospitals and the pharmaceutical, or the pharmacies, to basically capture that margin for themselves and pad their profits. Is that accurate?
That is absolutely accurate. And yeah, and there's a lot to be discussed here on it, but the real issue for us is that, if you're supposed to have a discount that makes its way to a patient and it doesn't, that's just really problematic. And so that's what we're really trying to solve. And there are so many loopholes in this particular section of law that it just needs to be fixed before it ever gets expanded.
I mistimed this segment. We're going to have to go to a break real quick, but we will be right back with Open Range to continue discussing this issue. Welcome back to Open Range. I'm Dustin Geverlow, and today I'm speaking with Kent Kaiser about the 340B program, which it relates to pharmaceutical drugs, pricing, hospitals, and how it's intended to benefit the patient, but in a lot of cases it might not be. So before the break, Kent, we were discussing the dynamics of this and how it was well intended. Let's get into how it's actually been incorporated and executed over these years, and where it's gotten off track.
Well, right, like I said earlier, the original intent of the law was to be able to make it so that the pharmaceutical companies would provide deeply discounted drugs, the prices, to the safety net hospitals and to what are called covered entities. And those covered entities are ones that serve the most vulnerable populations. And the real problem came about when the for-profit hospitals started purchasing those 340B covered entities in order to gain access to the 340B prices. And so what you've got is a huge loophole here where hospital systems, which weren't really intended to get those discounts because they're not really serving the population, the targeted population, they started getting those deeply discounted drug prices for themselves. And then, of course, they're allowed to charge retail price or full price to the insurance companies, or even if a person's not insured, they would just charge it to them. And that includes to Medicare, Medicaid, and to state health plans, for example, where state employees are using their health plan. And one of the other really big loopholes here, or problems with this law, is that nobody really knows that they are a 340B patient. You might go in, any of us might go into the pharmacy and pick up our prescription. And if it's one of those drugs that's covered by this law, we might just pick up our medication, maybe pay our copay, but then the pharmacy can go about charging our insurance the full price and reap that windfall for itself, and we never even know about it. So it's kind of goofy, you know. Like, people often talk about the fixed the 340B program as sort of an entitlement program, but it operates completely unlike an entitlement program, because like when you're part of an entitlement program like Social Security or welfare or food stamps or something, you know that you're a recipient, you know that you are part of that program. But with 340B, you might not even know that you are being considered one of those patients, and because you don't actually receive any benefit. You know, the benefit is going entirely to the pharmacy or the hospital system or whatever. And so that's a huge problem. And one of the things that really needs to be fixed about 340B before it's ever expanded. And I've mentioned expansion because that's what many states are wanting right now, is expansion of the program, but really it needs to be fixed so that, first of all, the money that's being saved on these drugs that savings should be passed on to the patients, obviously. But also the patients should be aware that they're eligible or that they are a 340B patient. And there should be just so much more transparency and accountability in this program for any of the entities that are taking the 340B profits.
Yeah, and when I was researching this issue, I found a site and there was a map of safety net hospitals, and in Bismarck here, it listed Sanford Health as one. It didn't list CHI St. Alexis, which is the second hospital here in town. But you mentioned 2013 because that was a critical year for a lot of things healthcare related. That was when the Obamacare Medicaid expansion went into effect. We had a special session up here to adopt the expansion plan. That was the year that Sanford Health took over MedCenter 1 here in Bismarck, and that is the safety net hospital in Bismarck. And then that was also, I believe, the legislative session that the state of North Dakota switched its healthcare insurance provider from Blue Cross Blue Shield of North Dakota to Sanford Medical Plan or Health Plan. So it seems like there was a lot of convergence there in 2013 related to this. And I'm wondering how much of the incentive to do those things that year and in that time period revolved around either this program or other programs like it.
Well, it seems like there was a moment of discovery among all of these hospital systems and pharmacy chains and so on to figure out how they could make the most money, of course, from 340B and from these other programs. I mean, it was interesting how so many people got channeled into Medicare and Medicaid around that period. And there's just a lot of the vertical integration among these different healthcare plans, the hospitals and the pharmacy benefit managers. It's a system where the incentives are all really misplaced. I mean, and I mean that in the sense that they're placed against the patient. And so you really have, like, these pharmacy benefit managers are supposed to be negotiating the best prices, but they have an incentive to make it so that you buy the most expensive drug, not a generic. And there are incentives, of course, for them in relation to the 340B program to get the most expensive drug, because then they can have the biggest margin and keep that windfall for themselves. And so, yes, 2013 and after that just seems like it was a big time of discovery for these systems to figure out these loopholes and, different ways that they could vertically integrate so that they make money coming and going in a sense. And so unfortunately, the program hasn't done what it was meant to do, which was to serve people who needed lower drug prices. But it has certainly lined the pockets of the big box pharmacies and the big hospital systems. And like you say, it's not all hospital systems, it's certain ones that are contracted with the federal government for these, for the 340B program. And it's not all pharmacies. And that's one of the big problems we see too, is that it really is some of the biggest pharmacies in the country, the biggest pharmacy chains, places like Walgreens, CVS, Walmart. Those are some of the biggest pharmacy chains in the country. And so we're not talking about your mom and pop Main Street drugstore at all. In fact, they are very much disadvantaged by not being part of the program, and they're actually being put out of business because of the consolidation within the program since like 2013.
Well, we've got to take another break here. When we come back, let's talk about HB 1473, how it plays into this whole dynamic and what should be done in North Dakota. We'll be right back with Open Range.
East Fluke Trailers of Dickinson is a family-owned.
Welcome back to Open Range. I'm Dustin Geverlow, filling in for Gary Emeneth today. And with me is Kent Kaiser with the Domestic Policy Caucus, and we're discussing the 340B program as it relates to healthcare and pharmaceuticals and hospitals in North Dakota, as well as we're going to get into specific legislation that the House is looking at next week, HB 1473, which, Kent, my understanding is it is looking to expand the program, but not actually fix the problems that are already inherent with the program.
That's exactly right. What they're trying to do is extend it to more pharmacies in the state. The problem is, well, there's a couple of problems. One, it isn't really clear that they're allowed to do that because it's the federal law we're talking about here. But what's really a problem, again, is the fact that we don't even have a definition of what a 340B patient is. And there are very few guardrails on this program. And so you have not much accountability and virtually no transparency over how much money we're talking about, where that money is going, whether any of it is going to the patients or how much of it's going to the patients, and how much of it is going to line the pockets of executives at these health systems or at the big box pharmacies and the pharmacy benefit managers, which again are supposed to be negotiating better prices for all of us, but they really don't have the incentive to do that. And what really happens, what we've seen happening all across the country over many years now, is the consolidation of pharmacies into these big box chains and so on, and really putting out of business these small mom and pop pharmacies on Main Street. And for a rural state like North Dakota, and this is true all across the middle of the country, of course, that there are what we call pharmacy deserts, and that's a place where you have to travel more than 15 minutes to get to the nearest drugstore. And there are many of those in North Dakota. In fact, North Dakota is among the states with the most counties that have pharmacy deserts all across the country. And that's a problem, because I mean, you might think, well, it's not that big a deal to have to travel 15 minutes, but when you're sick and you're trying to get your medications, it kind of is. And when you think about the kind of pharmacy that you're going to, if you're able to go to a Main Street mom and pop pharmacy, those are probably people who know you and probably care about you, and they provide more than just drugs. They often provide a lot of other health advice and really flag things that are maybe the doctor didn't catch, or they're going to catch it like a doctor would. Whereas if you're going to the big box pharmacies, oftentimes those are really just a transaction where you're picking up your drugs. And the worst situation, of course, in terms of that kind of personal care, is the drugs through the mail. It can be convenient, but you're getting absolutely no personal care when you go through the mail. And that's what a lot of people are being forced to do, because they live in these pharmacy deserts, and and really can't travel that far to get their medications. I mean, I know when I used to live in a really remote area where it was an hour to the nearest pharmacy, and if that pharmacy were to go out of business, it would be 2 hours a drive to just one way to the nearest pharmacy. And so that's a real hardship in many parts of the country where we have these pharmacy deserts. But that's what's being created by in part by the 340B program and the incentive to consolidate these big box pharmacy chains and really put mom and pop out of business on Main Street. So so we're really interested in reforming 340B before it's ever expanded. And so that's what we're encouraging of the North Dakota legislature, is to just kind of take a pause, step back, make some common sense revisions to the 340B program for the state. And again, it's a federal law, but I mean, in this, the DOGE kind of environment that we're in nationally at this point, it should be easy enough to get a waiver to try new things in North Dakota and to make the 340B program work. In fact, North Dakota could be a shining example to the rest of the country on what to do with 340B. And again, just being able to name what is a 340B patient and to let the 340B patients know that they are one would be a big step in the right direction, as well as some transparency and accountability, so that really the books should be open on this money that is flowing into the hospital systems and the pharmacy chains, so we can see how much it is and exactly where it's going and whether it's going to the patients it's supposed to serve.
So, you know, North Dakota is one of those unique states. I don't know if it's the only state. I think Nebraska also has a pharmacy ownership rule, but North Dakota probably has the most strict, where our pharmacies are required to have 51% ownership of a North Dakota registered resident licensed pharmacist. And that typically has, in the past, kept a lot of the big box stores out, like Walmart. I know that back in 2014, I believe was the last time it was attempted to reform that ownership law. It failed miserably on the ballot through a ballot measure. A lot of people think that Walmart came in with too much money and tried to overkill the issue and failed in the process. But you've said that this 340B program benefits the big box pharmacies more than the mom and pop. Does our pharmacy ownership rule probably magnify that problem a little bit?
I don't know whether it does or not, but the fact is that the pharmacies that are allowed to be contract pharmacies in the 340B program are typically not the small mom and pop. In fact, they're really not at all. It's these big chains that are contracted. So that's where the problem comes in, because then a person goes to get their prescription and they're forced to go to one of these chains or one of these big box that are contracted with the federal government for Medicare and Medicaid. And so they're not even allowed to go to, well, I suppose they're allowed to go to their mom and pop, but then they'd be paying full price, so they don't. So that's really kind of the problem, is forcing the patient to go to a specific pharmacy, which is one of the contracted pharmacies. And again, if patient wouldn't even know that they're supposed to be getting a discount. And what we've seen happen, especially with hospital systems, is that they take that 340B windfall and they plow it into things that aren't serving the people who are the most vulnerable. You'll see them actually put up new facilities in wealthier neighborhoods, and they'll put in facilities that really aren't geared toward the patient population that 340B was meant to target.
Kent, we got to take another break here. When we get back, let's talk about what citizens should tell their legislators and what legislators need to know about this issue.
Hey y'all, it's Trent on the loose. I want to tell you, Lady Blue and I, we got a lot of money.
Welcome back to Open Range. I'm Dustin Geverlo, filling in for Gary Ameneth, and with me today is Kent Kaiser of the Domestic Policy Caucus. We're discussing the 340B pharmaceutical issue as it relates to pharmacies and hospitals in North Dakota. This HB 1473 is coming up next week in committee, and this is a very in the weeds, nuts and bolts type of issue that not a lot of people, not a lot of legislators have been exposed to. So what is your direct message to legislators on this issue, as well as what do you want their constituents to know and tell them if they are concerned about this?
Well, yeah, constituents can call their legislators and tell them to oppose House Bill 1473 at this point. And what we're asking legislators to do is to shelve House Bill 1473, put it, just reject it, and come back with a real reform of 340B. Again, North Dakota legislators could be real leaders in the country by injecting some real reforms into the 340B program. And maybe it requires a federal waiver to do certain things, but in this particular environment right now with the new administration, that's probably an easy thing to do when we're talking about reforming a program and making sure that the money gets to where it was intended to go, which is to the patients. And so a few of the reforms that the legislature could really take on, and again, be leaders across the country, would be to, first of all, define what constitutes a 340B patient, and to make it so that 340B patients are aware that they are a 340B patient, so that they know that they should have some kind of drug discount coming to them. Right now, people don't even know that they're supposed to be getting a discount. And then there should be transparency and accountability. And so the transparency, we should be able to see, because this public program, we should be able to see the amount of money that the covered entities and the hospital systems and that the pharmacy chains, how much money they are getting as a result of the 340B program. Right now, they're not required to say. And then we should be able to also know exactly where that money is flowing to, and just exactly how much money of that is going to the specific patients and how much is staying with the hospital systems. And this should be a real concern too for legislators, because they are part of a state healthcare plan. And we had a treasurer in the state of North Dakota, or North Carolina, I should say, where the treasurer actually commissioned a study of the 340B program there and found out that the taxpayers were really getting screwed, essentially, because the same thing happens with Medicare and Medicaid, where a patient goes in, gets their medication, and they're on the state health plan. So maybe they work for the state of North Carolina out there. And in the case of North Dakota, of course, they're going and getting their medications, and then the state health care plan gets charged the full price for that medication. Well, of course, that's coming out of the taxpayer's pocket. And that should be of a concern all across the country. And we should be able to see that. No, I mean, maybe there are people who work for the state who, of course, need a discount on their drugs. Nobody's arguing about that. But we should be able to know exactly how much money the taxpayers are putting into that. And right now, there's no way to know. And so that's just one component of it, the state health plans, or the health plan for people who work for the state. But it's just as much of a problem with Medicare and Medicaid. Of course, there we're talking about federal tax dollars. And then with your private insurance, it drives up the cost for everybody, and for every business across the country and across North Dakota. Every business is paying more because of the fact that there's this amount of money that the pharmacy chains and the hospital systems and the pharmacy benefit managers are kind of skimming off from the 340B program and taking for themselves rather than passing on to the patients. And so, with your private health insurance through your employer from a private company, of course, they're paying more for their coverage, and so it's costing businesses all across the country, across North Dakota, which it shouldn't be. We should know where that money is flowing. So those are some things that the legislature could do, and again, be real leaders all across the country for doing it.
When we talk about these healthcare issues, oftentimes the companies themselves come out and say that they can't comply with transparency requirements because of trade secrets or issues like that. And then the philosophical conservatives will say that we don't want to put more regulations on companies and require them to do more reporting. What kind of counter argument to any of those defense mechanisms would you put out there for folks to consider?
Well, there really isn't any consideration here in terms of, who the individual patients are. Nobody needs to know that. Nobody needs to know anything about any kind of trade secrets, because really the price that you're charging for a drug is supposed to be public and not private anyway. And so those shouldn't be of concerns. And so we really should be able to have some accountability injected into the program. And in terms of sort of that libertarian idea of not having regulations on companies, in this case, we're talking about this massive, well, a couple of massive loopholes and money flowing not to the people that it was intended to go to. And so I think even the most conservative person would probably agree with injecting the accountability so that we can know where these dollars are flowing, because it's costing everybody. And it's kind of a scam. And when you think about it, when the money's supposed to be flowing to patients who need it, but they don't even know that they're eligible. And so these health systems and the pharmacy benefit managers and the pharmacy chains just take that money and often use it to their own benefit, not to the benefit of the patients. I think most people would probably agree with injecting some accountability in the program so that we could know all that.
I guess that's one detail that we skipped over. How is the 340B program funded? Where does the money come from and through?
Well, there's those discounts, of course. So the discounts are mandated from the pharmaceutical companies, and the pharmaceutical companies were in favor of this program when it was first put in place, because it's a way for them to do good, of course. But so where the money comes from is then from the covered entities and so the pharmacy benefit managers, the health systems, the pharmacy chains, from the profit that they're able to charge. So they get the drugs at a deeply discounted price, they sell it at retail price, and that windfall of money is how the program is funded. And so, depending on where the insurance is, that's really what's funding the program. So it's Medicare, Medicaid, your state health plan, and your private insurers that are ultimately paying for the program.
Okay, we got to take another break here. When we come back, we'll finish up this discussion and clean up whatever we've missed.
We are rewriting Hollywood's script for our kids. I'm pop culture expert Tina Griffin.
Welcome back to Open Range. I'm Dustin Geverlow with North Dakota Watchdog Network, and I'm speaking with Kent Kaiser with the Domestic Policy Caucus, and we're finishing up our discussion about the 340B program with pharmaceutical drugs in hospitals. We've discussed how this plan and program is intended to work, how it's not working, and we've discussed the fixes that we should implement and promote amongst legislators as far as transparency and that sort of angle. Are there any states that have gone down the road at all of trying to fix this, and what hurdles have they found in the process?
So far, not really. And so that's why it is a problem across the country, although there are a lot of states that aren't trying to expand it like North Dakota is. So that's what's most problematic. And North Dakota is trying to expand a program that really needs to be reformed before it's ever grown to be bigger. And, again, this markup program, I mean, because of the loopholes, it's really become a hidden tax on employers and patients and state employees. You don't really see it because it flows through the insurance programs, but marking up the costs of the 340B medicines for like employer-sponsored commercial plans and patients with private insurance generates a really big, significant revenue for these 340B hospitals and pharmacy chains. In fact, one study found that 340B hospitals collect 7 times as much as independent physician offices for the sale of medicines administered to commercially insured patients. So if you have private insurance, there's a huge markup there that you don't see. And that really is a tax on sort of on you, but really on your employer. So ultimately on you. And that's the thing is it's, you know, the way this money flows, it's just so hidden and it's really problematic. And so again, I really think that North Dakota legislators could be the leader nationally in injecting more accountability and transparency into the program. And some states have done studies. I mean, Minnesota had sort of a study. I mean, it wasn't as robust as it could have been, but seeing where the 340B money flowed, and of course, finding that it's really not flowing to the patients like it should, and how much it's flowing to the hospital systems and the pharmacy chains. And North Dakota could do the same thing. I mean, North Dakota could do such a study, but North Dakota really could leapfrog all of that and just inject these common sense reforms of accountability and transparency, defining who a 340B patient is, and making sure that 340B patients know, in fact, that they have been identified as one. By doing that, North Dakota would leapfrog anybody else who's just currently sitting there and studying. Like I said, North Carolina and Minnesota have done studies on the 340B program, but haven't implemented reforms. So North Dakota could leapfrog all that and be the example to the rest of the country on what to do.
So House Bill 1473 is sponsored by individual legislators, and it did not come out of the interim committee process. So it was not a result of a study, but it is poking into a very specific issue and program at the state level. So somebody has brought it forward to the legislators that have put their name on this bill. Whether or not the committees have enough information to even discuss this, let alone the entire chamber, is going to be an interesting thing to observe, because it does look like perhaps this is one of those bills that is designed to catch people's attention by the fact that not a lot of people know what it's about, and that typically when that happens, these type of bills do get converted into study resolutions or study bills for the next interim. And in the last couple of sessions, we've had a lot of bills related to PBMs, pharmacy benefit managers, price control type of approaches, tying things to Canadian prices. It's run the gambit on this issue. And my guess is that this kind of metastasized from that discussion a little bit and is not necessarily particular to what, let's say, the health department or the entities that manage the Medicaid or Medicare programs, either at the state or national level, are actually discussing. This is somebody's just throwing this out there to get some attention. And hopefully at the committee level, when this is heard next Monday, I believe in the afternoon, the legislators that are there will be told that, yes, this is an issue, but this bill in particular is not the direction to be going.
Right. Yeah. The hearing is Monday at 2:30, and right. I mean, it's like exactly like you said. It sounds good on its face, because I mean, 340B drug pricing program was originally set up to provide lower prices to patients in need. And it sounds wonderful, doesn't it, to expand that? But the fact is that that's not what the program actually has been doing. And so it would be expanding a program that's not meeting its original intention. And in fact, it's just lining the pockets of these hospital systems and pharmacy chains. So again, the thing for North Dakota to do is to maybe do a study. But I think that the North Dakota could leapfrog all the rest of the country by injecting just some transparency, some accountability, defining who a 340B patient is, and making it so that 340B patients are notified that they are in fact a patient, so that they know that they should have some discounts coming to them. If North Dakota did that, it would be absolutely a leader for the country. And it would probably, I mean, that's at least as cool and glamorous a bill. If those reforms were passed and put into a bill, that would be at least as cool as trying to say, oh, I want to expand this 340B drug pricing program, because I think people could see the tangible benefit of knowing that they were a 340B patient, that they had a discount coming to them, and for the hospital systems and pharmacy chains to have to open the books and say, here's how much money we get from this program and exactly where it goes. That would be interesting stuff for everybody. I think voters would love to see that.
Is there model legislation out there that could be adopted? And we only got 1 minute left.
Not that I know of, but I'm not totally knowledgeable on the legislation. I'm knowledgeable on the legislation that has been popping up in these states, like what's popping up in North Dakota, and it's popping up in a couple of other states too. And I just know that it's expanding a program that needs to be reformed first.
Yeah. Well, thank you, Kent, for joining us. And if anybody wants to find out more about Domestic Policy Caucus, they can go online and find that out. If you want to know more about my work, go to watchingnd.com with the North Dakota Watchdog Network. I'm Dustin Geverlow, and thanks for tuning in tonight.
Now you can have the personalized forecast at your fingertips when you need it. Beck's exclusive Weather Insight is information tailored to you. Radar, weather alerts, forecasts, and videos. Download the free Weather on Beck News app. Search your app store now.
We're the ladies of Another View. Join us at 9 a.m. weekday mornings.
We'll discuss issues you care about from local and national perspectives.
You'll hear unique stories from fellow North Dakotans, plus topics in the national spotlight.
Start your day off right with Ladies of